Hi, everyone, and welcome to 2019. Erica and I are excited to bring you another year of podcasts of our Tough to Treat clients. Stay tuned and listen to some of the most interesting episodes that we have lined up for you this year. In this particular episode, we actually take you on a tour of how to work with somebody virtually. This is an interesting client because she actually got injured at sea. Yes, literally at sea. So enjoy the podcast and welcome to 2019. Thank you. Hello, everybody. This is Susan Clinton, one of your hosts for Tough to Treat, and I'm here with my partner, Erica Mello. Hi, Erica.
Hi, Susan. How are you?
I am well. How are you?
I am good, thank you.
At the time that we're laying this podcast down, it is a couple of weeks before Christmas, right?
Correct.
Less
I think
than that.
yes.
Just a little bit less than a couple of weeks before Christmas, and we're wrapping up the holiday season ourselves, which is kind of fun, and looking forward to getting together in the New Year's.
Yeah, and I think this podcast will air in the New Year, the first one.
So Happy New Year, everybody.
Happy New Year, everybody. Sounds weird saying that before the end of the year, but
it is weird. It is a little bit weird, but I want to welcome in 2019 with bang, for sure.
Exactly.
Okay, are you ready?
I am.
Okay, the person I want to talk about today is a 63-year-old female who resides on a sailboat most of the time, and got in touch with me because she was having posterior hip and back pain. This was a few years ago, and she happened to be on land, and we worked together a little bit. She had fallen on the stairs in her boat and, kind of fell onto her pelvis, which is kind of the one time that, I kind of start thinking, oh, maybe this really is an SI issue because it was a pretty hard fall onto her pelvis.
Yep.
So the back stuff was all negative. So she didn't, the pain that she was having in the back of her pelvis that kind of went down to her mid-thigh.
Which side?
Didn't centralize with any back, extensions or motions and all of that. So the back didn't change her symptoms at all.
Okay.
Standing on one leg made it worse, and she was unable to even try to hop on one foot. Other than that, she moved around pretty good. She just said it was aggravated all the time.
Which side, Susan?
The right side.
Okay.
So we just did some, easy stuff. We moved without it hurting so that she could get an idea of how to kind of sit down, stand up, climb up and down stairs and move around and really kind of pay attention to her symptoms and not feed into them. So we did some of that stuff. And then we just did an old-fashioned grade 5, in Pennsylvania, we call them grade 5s. For everybody else, they're called manipulations. But I just did a basic manipulation to her pelvis and her right hip and alleviated the pain immediately. And I used your trick, Erica. We did some taping.
Oh, nice.
Because she was having difficulty. She wasn't having pain anymore standing on one leg, but she was having difficulty sorting that out. So, and I think it was just the muscle inhibition on that right side from the pain. So we kind of went back to doing a couple of the movement patterns again so she could see how she could move. And all I did was I just actually had her sway forward slightly on her feet. So she would get off of her heels and a little bit more towards her toes. And when we did that, she was able to stand on one leg much easier. So just putting her in a different position for her glutes to work really helped. So I taped her. And, to where that
how did you tape her?
Get a facilitation to the glute muscles.
And how did you tape her?
So basically, I went from in front of the trochanter on the right side and wrapped the tape around the back side of the pelvis towards the sacrum.
Got it.
And I did that 3 times, so you kind of have a fan of direction going towards the sacrum.
Yep.
Just to give her, I think more than anything else, it made her feel stable on that side.
Yeah.
She just felt like she had some oomph there. So we did that, and then she went away, and I told her, I said, use the tape. She could tape herself. I gave her some tape. I said, if you feel like you need it again, go ahead, get in touch with me. So she just got in touch with me by, I believe we did like a phone call, a couple of weeks later. Things were going very well. no problems. And then 2 years later, I got an email from her, actually from her husband, who happens to be a physician, and
Mhm.
she's a physician as well. Um, and he said that she had, this is a bit frightening to me, but
Mhm.
what they have is they have a pontoon sailboat,
Mhm.
and so they've got 2 holes, and they do all of the maintenance on it themselves most of the time.
Mhm.
And I guess she was walking across the end plate, or the side plate. I don't know boat language. He just explained it very better. But there's all these hatches and windows,
Mhm.
and I guess they were open, and she stepped right through one of them.
Oh my God.
I know, right? I was just like,
Oh.
ah!
Oh.
Who's having the central nervous system reaction, me
I
or the
know.
patient,
I
right?
know. I
It was
know.
like,
Oh.
whoa. So anyway, it was very interesting. He had done, he said, I've checked reflexes. They were in a place where they could not get back to land
Oh
to get
boy.
to an ER. So he said that, he knows that everything was okay. He was looking at cardiovascular, in the leg and reflexes and sensory. And he said, everything looks good. He was concerned about a compression fracture, as I was. I was like,
Right.
ooh, or a pelvic brim fracture or something.
Mhm.
I said, can anybody tell me where she hit? We were kind of texting back and forth at that point. What happened? Where did she, where was the impact? And, so actually, we got on the phone. I got on the phone with her, and she said she kind of fell into a sitting position. If does that make sense? So she didn't fall
Mhm.
straight through, like all the way to her pelvis. She just kind of
Mhm.
like the leg went in, and she kind of collapsed down onto the right side,
Got it.
like kind of down into a partial sitting with your leg
Mhm.
sticking through a hole kind of thing.
Oh
I
Jesus.
know. So, and the biggest problem she was having was, she said, I have trouble weight bearing. And I'm
Yeah.
like, oh, okay, well, you're out at sea. You're
Oh.
not going to be able to get anywhere. Let's figure this out. Let's just go with the best instincts you have for acute care, right? It's like,
Right.
okay, so what we don't want you to do is we don't want you to weight bear too much. Let's figure out how you can move and how you can take care of yourself and do the things you need to do. And, her husband said he would watch all the signs and symptoms of everything. So, they were okay. I mean, I guess if they had to have called uh, uh, a rescue boat or something, they could have,
Mhm.
but they really felt like that this was just musculoskeletal. And she said, even if it is fractured, what are they going to do for me? Nothing. They're just going to tell me to go back and be careful and not do
Mhm.
anything.
Yep.
And she said my leg isn't at a weird angle. She knew she didn't have like a femoral neck fracture or something like
Yeah.
that. It was, she felt like, she said, at worst, if it was anything, if it was a pelvic fracture or a lumbar fracture, she goes, there would be nothing they could do anyway, and
Right.
unless I was having signs and symptoms of all the
Right.
neurovascular stuff. Like,
Yes.
well,
Yeah.
what am I going to do? 2
Right.
physicians there. I'm not going to talk them out
All
of
right.
what I think, but I
Exactly.
said, okay, let's just figure this out.
Right.
So it was interesting. She was I said, what can you do and what can't you do? And she said, the worst part is walking, of course. She said, sit to stand is not good. And she has to go up and down the stairs on 1 foot, which she can manage quite easily because the stairs that they have are kind of straight up and down with handrails. So you can
Mm.
kind of grab hold of the handrail and hop yourself up.
It's a big
Um,
boat.
yeah. Well, it's actually, it's not as big as you think, but the way that it's put together is very efficient. And so
Mhm.
they've got 2 berths on either side of the main galley, which
Mhm.
stretches across the 2 holes that are part of
Mm.
the catamaran.
Mm.
So anyway, what did I say earlier? It was a pontoon boat. Sorry, no, it's
Yes.
a cat.
Pontoon.
It's a cat.
Oh,
Yeah,
cat.
catamaran.
Okay.
Yeah, so it's a double hull.
Got it.
Anyway, so she was able to get up and down the stairs somehow, which was good. And her husband was there to help her, which was also good. And so I talked her through at this point. I said, all I can tell you to do for walking is put a towel on the floor and see if you can slide your foot with a towel.
Great
Didn't
idea.
have any resistance on there. So
Mhm.
she, so her husband went and grabbed a towel and they practiced it there. I mean, we were like on the phone, right?
Mhm.
They didn't have really great internet. We were talking on the phone, trying to get through some of this stuff. And so she was able to do that. So that helped immensely, because trying to lift her knee up into flexion really, really was hard to do.
Okay.
So, and it was like, okay, so the only other thing that I could, I said, you're not going to just avoid doing that as much as you can.
Yep.
Just let that go because it hurts too much. Just let it be. And I said, let's think about it this way a little bit. How do you get up and sit down? And she said, well, very gingerly. And I said, okay, why don't you try this? So I said, just get to the chair, and bring your legs apart as far as you can and see if that makes it a little bit better. And that did. She said, I'm okay with that. I think I can do that. I said, okay, so try that every time because you can't just lay down all the time.
Right.
And there really isn't the most comfortable place in the world in the galley for her to lay down all the time. There's not a lot of room up there.
Yeah.
So anyway, so we said, okay. And they said that they would probably be back closer to land in about 10 days.
Okay.
So I said, well, just get in touch with me however best way you can. Let me know what's going on. But, I said, and they knew all the signs and symptoms to watch for.
Yeah.
So they, I felt like that they had, their level, they were being somewhat level-headed about it. I'm not real sure why they didn't turn around and head back to land immediately, but wasn't my thing to talk about.
So you had her just sit there with her legs in sort of more of like a wide base of support and sit.
Yeah, just to move into sit to stand.
Got it. Yeah.
To sit down or to stand up seemed to help alleviate it.
Okay.
Started making me think that it was probably more back than hip.
Yeah.
Because it was weird because she couldn't do flexion, but the other part that was, she really could stand in abduction and sit down and stand up, and that made her feel better. And it was like, that's one of the Sarman tricks for, kind of moving through. If you take the hips out of it and see if you can get the back to move a little bit better or easier, or it takes stress off the spine if you can go into abduction for movement and things like that. And I was just trying to do anything I could to get this stuff off. So then it's very interesting. What happened was they got in touch with me about 10 days later. And they were where they had internet, and they said, can we just get on an internet call and do this? And it was like, sure. So they got on their iPad and I got on my computer, and we did a Zoom link and kind of, a friendly telehealth basically.
Yeah,
and, on a boat. Yeah, exactly, right? So we got on and I could see then at that point, and I said, okay, so first things first, I just need to look at you. So, so I told him, I said, you're going to have to move the camera around so I can see what I need to see. And so first of all, I just looked at her in standing, and she was really clearly standing on the left leg, and the right leg was externally rotated and kind of abducted out to the side. And I just asked her, I said, the way that you're standing right now, are you having symptoms? And she said, no, I'm very comfortable in this position. And I said, okay, so what happens if you just make your toes point forward on the right? Well, that bothers me a little bit, but not bad. What happens if you bring your foot in and you actually begin to put weight on it? Then she started pointing up, to the top of her pelvis, not the bottom. Up to the top of the pelvis, around, again, around what, people would say, oh, SI, and maybe higher than that. She goes, it's really, and then she goes, and then it goes down from there. I said, okay. I said, does this feel like what happened to you the first time when, we worked together and I taped you and all that? And she goes, no, this doesn't feel like that at all. It's like, okay, that's good. I wanted to see, what was familiar and what wasn't, and what she felt was different. So I just had her, I said, I just need to see your skin. I just wanted to, after 10 days, I didn't expect to see bruising, but I just wanted to wanted to look.
Yep.
So, she pulled her shorts down and took her shirt off so I could see her back. And there was a line of bruising that went across the top of her pelvis and, across the top of her lumbar spine.
Oh, boy.
Very interesting, because it was like, okay, if it really had been a hip injury, like something directly into the hip, like, a compression or a stress fracture or something into the hip, the bruising would be down the leg.
Yeah.
It wouldn't be up there. And it's like, okay, tell me again how you hit. She just said, I ended up kind of in a, kind of sitting on the edges of the window on that right side. So that kind of
Mm.
made some sense to me. She said she had some bruising below, but it went away. This one was the worst.
Wow. So
And
it was
so to,
across the back on
yeah,
down on the right side.
so she
Wow.
must have really, really slammed into that
Yeah.
window frame on
Yeah.
that
Yeah.
side.
Yeah.
So anyway, I had her bend over, which was no good. She didn't like that. She could extend. That didn't really change her pain a lot, but if she stood with her foot out to the side, she felt much better. Again, we're back to that kind of like, if I can just stand on my left leg, I'm good.
Right.
The weight bearing is better on the right leg than it was. I can do it. I just don't like it.
Right.
When she bends over, everything was worse. When she went back into extension, it wasn't worse, but it didn't really like drastically, it wasn't like, oh, I have no pain or just pain in my
Right.
back, like you would expect to see with, kind of a disc problem or
Right.
something along those lines, a
Yeah.
directional preference.
Right.
Side bending was way worse to the right, not so bad to the left, which was interesting. So
Yeah.
compression to the side and
Huh. And
flexion
forward
forward
bend.
seemed to be, so it was kind of building up into kind of a flexion quadrant pattern,
Yeah.
which was very interesting to me. So, but it happened in flexion, which kind of makes sense too.
Right.
She ended up in a flexed position when it happened over to the side.
Mm-hmm.
So compression basically was still no bueno for her. She just really
No.
didn't like it. She didn't like to compress down onto the right side with side bending. It seemed to be worse in flexion, less bad in extension. Couldn't really, flexion definitely made it worse. Extension didn't really change it. So
Mm-hmm.
it's hard to say one way or the other. I just went with the compression side bending kind of
Yeah.
piece because when she would pull her leg out to the side, it would take her out of some of that compression. As she
Right.
brought the leg back underneath her, you could see that she would actually draw over to the right. So I'm looking at this going, what is going on here with that pattern of movement? Because you would think that she would want to like lean to the left as she brings her foot underneath her to get
Right.
out of compression. But what happens is her body just actually side bends and compresses in more.
So it's interesting though. The forward bend made her worse, and the side bend right made her worse.
Uh-huh.
The extension did nothing,
Right.
and side bend left was okay.
Yeah.
Okay. Interesting.
Again, the motor pattern that had developed around this with the protection response, I'm sure, was,
Mm-hmm.
wanted her to stay out of compression. And
Mm-hmm.
so every time she brought the leg underneath her to stand on it, there was like this side bending that went on, and it made the compression worse,
Yes.
fine, and
Yeah.
it made her pain worse.
Yes. Yes.
So
Yes.
we
Of
had two
course.
different mechanisms. I could either side bend her and make it worse, or I could bring her leg underneath her, and she would get pulled into side bending, and that made it
Mm-hmm.
worse. So it's like, okay,
Yes.
so at least we know what we need to stay out of at this point.
Got it. Yep.
So I had her stand with her legs underneath her, and I said, just see if you can side bend, out of it. That wasn't really working.
Mm-hmm.
So I said, why don't you just do this? Take your right hand and raise it up towards the ceiling.
Mm-hmm.
I'm just kind of thinking, how can I trick the brain into doing something
Right.
a little bit different?
Yep.
And she goes, and it was really funny. There was this huge pause, and she brought it down again, and she said, no. And then she did it again, and she goes, okay, I'm not sure what just happened, but when I raise my arm up, it feels better.
Yes, of course.
And it's like, well, it's kind of a little bit of a trick because I couldn't get you to get your trunk out of, that right leaning sideways, but when you raised your arm up, you immediately did.
Yeah.
So, and she goes, well, am I
Decompress.
supposed to walk around with my arm up in the air? And it's like, well, maybe for right now. No,
Now, yeah.
it was a good laugh, but
See,
it was like, actually, let's explore that a little bit and see what we could do.
So you had her do that. I'm sitting here with her right leg abducted or with her right leg in?
With her right leg up underneath her.
Okay, underneath her. Okay, so she did that. She decompressed that right side. That makes sense. But what's interesting to me is why would forward bending and side bend right? Because they're different, physiological movements or arthrokinetic movements on the spine, and why would that make her worse? And that's my only thing. And then the hip flexion, but the hip flexion, when she lifts up the hip, you could cause some compressive forces on that right side. So I guess that makes sense to me. But the only thing for me is that forward bend and that side bend right, unless she was so stuck and compressed that when she went to forward bend, she was not able to open up or decompress, right? That's the only thing that for me that doesn't jive. But now that I'm talking to you about it, if she's so stuck in that compression, can't get out of it because it's how long now, like 10 days or something since the initial injury. She's compensated, but when she elevates the arm above her head, she decompresses from above, and the nervous system is like, oh, I'm not moving my lower part of my body. I can do this now. And I also like the towel on the floor for walking. That's like brilliant. That is a great idea. So those are my thoughts for now. I mean, the whole thing for me was that forward bend, side bend, right? That didn't make sense.
Right, and it was so confusing because, you know, this is if you want to get your head all wrapped up in the biomechanical model, it's like this doesn't make any sense. So I had to jump out of that and go, okay, wait a second. Let's back up and let's think protection and motor control and why this pattern is set up. And what can I do to get her out of this pattern? And if I do, does that make her feel better? That was kind of, I had to kind of take a right-hand turn, you know, and say, okay, we went that way. I'm not really getting any answers. Thinking about the hip flexion, though, that was better this time than it was 10 days ago. So she could actually like lift her foot up and put it on the stair, you know, before she couldn't at all. But she still had symptoms with the hip flexion. And so I asked her, I had the opportunity now with her to be, you know, less acute. When you lift your knee up, where do you feel your symptoms? You know, I wanted to know, because again, you know, there may be more than one thing going on here. And she said, oh, it's on the backside. You know, I said, so nothing on the front of the hip or the inside of the hip or anything like that. She goes, no, it pulls in the back. And it's like, oh, okay, so that's just like flexion forward.
Correct.
You know, but still, why flexion forward? And you know, that kind of makes sense to me, but then the side bending is kind of weird.
I think you're right, though, that biomechanical model. I mean, look, you know, that's sort of what we learn in school and things like that. But as you progress in your career, you got to think more out of the box, and I think that's true because she's holding them like her quadratus lumborum or any of her stabilizers are just gripping, and if they're gripping so much just to keep her as a protective mechanism, she's not going to forward bend. It's going to aggravate it because the muscles won't lengthen. Right. So that's
exactly right.
Right, and that's motor control. So okay, great.
Yes, and what's interesting is the body sometimes it's crazy to me because it doesn't make any sense. But sometimes the muscles that are becoming overactive or working way too hard or in spasm, whatever words you want to use, oftentimes are ones that are tending to bring the system into into a pattern that's painful.
Yeah.
So for her, the muscles that were overworking and stuff in her trunk, like her quadratus and you know, different things on that side, that was pulling her more into side bending. So, and side bending was painful. It's funny how it works that way. So then she was forced to put her leg out to the side because it was the only way she could find comfort.
Right.
It's kind of like a lateral shift when you have an acute disc.
Yes.
You know, they do this crazy shift because it's the only way to get off of that nerve.
Correct.
And to be a little bit more comfortable, even though it hurts really bad. You know, it's they do, you know, they create these movement patterns to get them off of it because for whatever reason they're continuing to stay compressed onto the disc or onto the side. So I still wasn't convinced that she didn't like maybe break the neck of a Scotty dog or, you know, a transverse process kind of thing. But it wasn't, again, what were we going to do about it at this point? You know, I'm not an imager and I couldn't see, and she was not going to go to the ER. She just wasn't. She said, no, this is getting better. I'm just going to move through this. And besides, at this point, she said, I don't think I could climb into the dinghy.
Yeah.
So I said, okay. So she said, I'll be boat bound for a while and he can go in and get the supplies and stuff that we need. And so anyway, so her biggest thing was, I need to be able to move around this boat. Let's figure this out. So we did. So we went back to the sit to stand and the legs apart and that kind of thing. She was reluctant to bend over because the bending over hurt. So I had her stand in a wider stance and let her knees bend first and then hip hinge. You know, so she went down into kind of a squat, and then she felt like, oh, I really can bend over. What she didn't want to do was lumbar flexion.
Right.
You know, that's what she needed to avoid. So they had tape on board because I, you know, insisted that they did a long time ago, and she liked how it felt on her hip that time, so they had it in their bag. So I had her husband just basically tape her into a bit of extension in her lumbar spine. so that every
Mm.
time if she started to drop her chest and flex her spine, the tape would stretch and remind her not to move there, to move at the hips instead.
So what did you do, like an X taping, or did you do it on one
I
side?
thought about an X tape, and then I thought I want to actually see if I can't get her out of a little bit of that side bending. So I
Mm-hmm.
wanted to do something to see if I could actually inhibit those deep muscles on the right side of her lumbar spine. So
Mm-hmm.
basically, what I did was I did it's kind of an X tape, but it was just skewed a little bit. So there
Mm-hmm.
was a couple of strips that went straight up and down, and
Mm-hmm.
I had her lean back just slightly.
Mm-hmm.
Then he just put the leukotape on in the hypofix over it to kind of hold her, and then when she came out of the side extension, she would feel the tape pulling on
Yep.
her.
Yep.
So it would just remind her. All it was just a reminder, like, bend at the hips first rather than through the spine first.
Mm-hmm.
So
Mm-hmm.
people kind of have that movement pattern where bending over, even if they're going to do it with a flat back, they still have some flexion going on.
Right.
That didn't really work for her. If she could stay more extended, she felt better. So, and then I just took the other piece of tape. It actually came around the side of her waist, like
Mm-hmm.
above the pelvic crest right there, and just laid it along, just kind of sideways, going across the spine to the other side. And then
Okay.
I taped it, and it sounds like I'm pulling her into side bending, but what I was trying to do was just, it would be like if you had took your hand and put it right on the quadratus, like
Mm-hmm.
your fingers through the obliques and your thumb on the other side of the spine, to just kind of like, can we get this muscle to let go?
Mm-hmm.
Just to kind of, I just wanted to get some input into it. And we did that second because I wanted to see if it would help. If it didn't, we could take it off.
Yep. Yep.
And it did help. She liked it. Again, she said, I feel like I have something holding me, which is
Mm.
great. So
Yep.
she was able to kind of relax herself into the tape a little bit, which was good. But the biggest thing that it did for her was it just gave her a constant reminder to, as she started, she goes, gosh, I don't realize how much I'm bending and how
Yeah.
much it
Yeah.
hurts,
Yeah.
and because the tape would block it. Well, just give her that signal back. So she would just start to bend at her hips more and start to bend at her knees more. And she goes,
Great.
it's so much more comfortable.
Mm-hmm.
She found that she could actually bring her feet closer together to sit down and stand up. She could move around. It was much easier going up and down the stairs because she knew how to hold herself.
Mm-hmm.
And she
Mm-hmm.
could move her hips and her knees to do it, and her back was staying relatively, out of the movement pattern.
Mm-hmm.
So it's kind
Yeah.
of like Starman's work with, the tail wagging the dog, and
Mm-hmm.
or what's moving, right? We
Mm-hmm.
wanted, the flexion was, whenever she would start to bend forward, it was more of a lumbar flexion type of thing rather than a hip flexion,
Hip flexion. Yeah.
as the
Yeah.
primary mover. So we just
Mm-hmm.
basically wanted to bring the lumbar spine out of it somewhat and allow that pelvis and hips to move
Mm-hmm.
without the lumbar spine being
Fine.
involved as much.
Yeah. It's like the path of
Just
least
kind of switching
resistance.
it up, yeah.
Yeah.
And so that really helped. So that was the end of that. And she progressively got better. We talked by email and stuff like that. She was crawling around the boat and doing things and all this stuff. And then I actually had an opportunity to see her on land a couple of months ago. Not even a couple of months ago, about 6 weeks ago.
Mm-hmm.
And I just, we were talking and just catching up on everything. And later that day, she went out for a walk with her husband, and I remembered watching her walk, going, what is going on? And so I did, she left and went for the walk, and when she came back in and she was walking around in the kitchen, I just really noticed. I said, tell me what's happening with you.
Mm-hmm.
She goes, oh, I'm trying, I can't figure out how to stretch this out, but I've got this thing in my hip, and I just
Oh boy.
can't figure out how to get it out of there.
Mm-hmm.
And so the way she was walking is she was actually doing a full side bending lift on the right side to advance her leg forward.
Oh boy.
And so she goes, would you mind looking at it? It was like, of course I wouldn't mind looking
And
at it. Let's see.
and she was pretty much okay with pain and good to go.
Yeah,
So to speak.
the other pain, she could bend all the way over.
Yeah.
That didn't
Okay.
bother her. The
Yeah.
back seemed fine.
Yeah. Okay.
Side bending still wasn't quite so good, but it wasn't the booming stuff.
Yeah. Yeah.
Residual sequelae, things like that.
Got it.
Nothing that was upsetting her. It was just that, as they had been doing this walking thing because they were on land and it was their time to kind of just get out and move around and do some things before they headed back to their boat. And, she wanted to do that. So she was just kind of, plowing through it. But it was very, very interesting if you've ever seen anybody who has a really bad hip problem, it wasn't a Trendelenburg that she was doing. As she could stand on it, she was leaning a little bit. There was a bit of a lurch, but it was to the side of the problem, so she was, which is part of the thing. So she was dropping over to the side a little bit into the side bending, but it was much more of a failure to be able to really like lift her knee to advance it forward. She was just doing kind of this like circumducted. It reminded me of the old days when I used to see people who had hip girdles, when they would take off their femoral head and just let the tissue fuse, and that would be it. The people who either couldn't have a total hip replacement or one that, had advanced so badly that they couldn't do one, and so they just let the hip fuse, and so it never would bend. They walked like that, and I'm looking at this going, oh my goodness. So we took a look at everything. What she was, again, we were back to the hip flexion as being the problem.
Okay.
And but the pain was still back behind. I did a Faber test, and she was able to go into the external rotation part of the Faber test, but she got the immediate pain behind in the back end of her pelvis. And I said, when you're walking, is that your pain? And she was like, well, I think so. And it's like, okay, that's not really an answer. Is this pain familiar to you? Well, no, not really. Okay. I said, we're not going to grasp at straws. I said, we did it on the other side. It was fine. I said, I don't know. Let's just keep going.
You expect that to be a little off anyway with all the history and trauma.
Yeah, and stuff like that. So it was, but it wasn't what her stuff was.
Right.
So I did I just did a little bit of a scour. That was okay. But when I scoured over towards a deduction, that was a little bit frightening to her. She didn't like that. I said, is that your familiar pain? And she said, yeah, that's it. And it's like, okay, so so we did some stuff. I did a couple of just techniques to kind of see if we could change the movement pattern around a little bit. I know that in the in the MSI type stuff, her femoral head was coming up, going into flexion rather than rolling and going down the right way. So we just did a couple some posterior glides, and we did some things, and then started working on heel slides to see if she could actually re-coordinate and get those muscles pulling in a better position and direction, and not bring her back into it every time again, and just really isolate that out. And so we got that going, and that actually started to feel better. She felt like, oh, I can actually bend my knee up and it doesn't bother me so much. So I had her work on those. We put a strap underneath her thigh so that she could, bend up as much as she could and keep it still. And then she could use the strap to help bring her knee closer to her chest. And then she would have that to help her lower down. So we were just doing that for just a bit of, help and control and movement things. And then we needed to get up because, again, sit to standing on your feet and walking were going to be really important to her. So she could manage the sit to stand piece again. That was going well. And then when we got up and we started walking, I just decided, I said, can I take your shoes off? Let's see what's happening, because whatever, this thing has been going on for a long time, and I just really want to see what's happening. And I know we can go in and fiddle with the hip and get it better, and she would do better, but it just seems like she just keeps rolling back into something that's not that's not a long-term solution for her. So she took her shoes off, her feet off, and I had her start walking, and it was very interesting. That right foot, those toes were so pushed into the ground.
Oh, I bet.
It was amazing.
Wow.
I mean, amazing. It was like almost, I don't think the ball of her foot even hardly touched the ground because those toes were curling.
Oh my God. Talk about a
pressing down. Yeah, wow. And of course, it was worse every time she stepped onto her foot. Right? And then, but what's interesting was she wasn't having pain with weight bearing.
Yeah, but it's
she
almost
was
like
having pain with lifting her leg forward. So
yeah, but if she's not putting her heel down, it's almost like she's giving herself, a potential I didn't want to say upslip, but she's almost like she's hiking her hip by not putting
Yeah.
her heel on the ground.
Exactly. And so that's altering the swing because she
Yeah.
never can go forward,
Yep.
and she doesn't get dorsiflexion in her ankle.
Yep.
So the swing is limited, and she's having to do this funny thing to get out, and then she puts the foot back down, and those little toes just curl again, and it was like, ooh. So it was fun. We just stopped, and I had her put, the 3 points of her foot down onto the ground, the heel, and underneath the base of the big toe and the base of the little toe. And we just started doing, can you just lift your toes up off the ground and keep your foot on the ground? And can you, so I got down on the ground with her. I think you talked about this once in a podcast, Erica.
Yes.
About
yes, my runner.
Kind of, yeah. And, I actually had to get there and help her lift her second and third, goes up.
Yep.
And begin to learn how to like lengthen those and change that. And so we did some movement and some sways. And as she swayed forward, I, kind of gave her the instruction for those toes to go long. Those were your words that you had used before.
Yeah, that was the running and pelvic pain podcast. For
exactly. Yep. So we spent a lot of time working on that. And then we actually started moving it back into gait. And I said, just try that. Every time you step on this foot, see if you can just get those toes to go long. And, so she worked on that. And, we put her shoe back on. I said, now you got to be able to do it in your shoes. It doesn't go back to the other way. And that made a substantial difference for her. She just says, I don't know what this does, but it's changing something. And I said, is it changing it in a positive way that makes you feel better? Yes, for sure. I said, okay, that's your cue. So her big thing was, don't push through pain, let your foot grow long, and, just explore the edge of the movements there and see where you are, and, because she's a healthy person, she's going to keep moving. So it's just like, some parameters to think about so that this can get better so you can keep walking, which is important. So phone call last week. They were on their way to their boat, and I wanted to, just find out how she was doing and stuff. So we hooked up my phone, and she said, I said, so how does everything feel? She goes, well, the stuff you did to my hip was great, but she goes, I'm going to tell you, whatever that is with my foot, that's the key to everything that's going on, because something lets go in my hip when I let my foot go.
Yep. So
and I said, good. So are you walking easier? She goes, I'm walking pretty good. She goes, she said, I can walk about 2 miles without everything pulling in. And then when it starts to pull in, I have to make a conscious effort to let my foot go.
Yes.
So she scaled back a little bit, which was good. Very hard for her to do, but she did it. But that was the key for her, so all this time. And, I don't know if I had gotten to her foot earlier, if it might have made a difference or not, or if that's something that just kind of came on later. I was working with her, with the camera on the boat, just really trying to give her movement patterns and things that would help her out. But when I finally, could see her on land, it was great, to be able to, again, take yourself out of your shift. There was so much going on, and there wasn't going to be great follow-up because it was just kind of, all too disjointed and too far away. But really being able to, for this person with a hip problem, that you could find the hip problem. I mean, I found a problem in her hip.
Yeah.
But all of the things I was doing wasn't really changing what was happening in her hip in standing, weight bearing with walking.
Right.
I could get her better with like doing hip flexion. I could get her sit to stand better. All of those things were changing, but I couldn't get her out of whatever was going on in gait. And so I think the take home for this one is that you got to look up and down the chain everywhere. And, taking her shoes off and looking at her feet was amazing, because we were able to really start making some changes there. And they were profound changes that went up the chain immediately. And if I hadn't taken her shoes off, I probably wouldn't have gone that far as lengthening the toes and really making an effort to think about, that foot working in a much different way.
Yeah, it's interesting. Yeah, no, go ahead, Susan.
No, that's fine.
No, I was just saying that I think that's interesting because, the foot could have been in there, but it could have been secondary at some point. But then the secondaries become primaries, over time. And,
that's a good point.
He compensates. And, in my experience is that with the hip, well, the hip and the foot are so intimately related in terms of the rotational capabilities in their joints, and I have
and the
found,
neurology.
yeah, exactly, and I have found that, I am not sure what podcast this was that we did. Maybe I didn't even talk about it. I don't remember. She had hip surgery. This patient of mine for a labral tear, and it was not. I mean, her main issue was her foot, and I think that.
Yeah, we did do a podcast on that.
Yeah, we did, right? And it was the foot tends to become, whether it's primary, secondary, or tertiary, becomes a driver, whether it's 20% or 30%, but needs to get focused on in order to get long-term change. And I think that you're right, that looking at the hip and doing the heel exercise with the strap, and that's a great idea, will definitely get her better. But if she, is going to walk those long distances, the foot tends to really grip, especially in one-legged standing, in gaits, what is it, 40% on one leg, you're going to grip to try and stabilize yourself. And what's interesting for me is that when she wouldn't put her heel down, she's almost side bending to that same side. Here's the biomechanics again, but and that was what bothered her in the first place.
Right, exactly. I know. It's like, why this pattern? Why now? Yeah.
Right.
And so was it something learned that just kind of stuck in there? Because we get these patterns, and if they're protective patterns,
right,
which I felt like this one was, and the feet curling and the stuff was actually kind of a protective pattern because she knew it was going to hurt when she let go of her foot to pick her knee up.
Right.
And I don't know. I mean, I can't get inside her brain and say why it did it this way. All I know is that when we actually explored changing that made things different.
Yeah, totally.
And the difference was enough to allow her to move differently. And when she got variance in her movement pattern, she started getting changes. And, I just wanted to help her find a way to walk that wasn't going to be so excruciating. And that was the piece that did it, and she liked it so much. She had been working at it, in fact even started scaling her walks. Nothing else, I could tell her till the cows came home, you probably shouldn't be walking 5 miles with this kind of pain. That wasn't
not going to happen.
You're not going to do it. But when I could get her to feel how walking could be different, then it was so much more motivating to her that she started scaling her own walks, because she felt like, when I walk this way, I feel good.
Right.
When I start falling into my old pattern and my toes start clenching and I'm trying to do too much, I don't feel good. So she started, so her internal motivators kind of took over there, because I think she saw the possibility that I could actually probably walk longer down the road with less pain if I do this.
Right. And I think for the listeners also, the treatment, like, 'cause she's not on land obviously that much, but since the foot is the main issue, if she were going to come in consistently, and see you, I would probably focus more of the movement pattern, the corrective exercises on the foot. Walking heel to toe, doing foot control, and just getting her back on her heel, versus anything with the hip. And I think listeners, you can do a little bit with the hip if you want. I mean, but ultimately, she probably won't be compliant, because the foot's the main issue. So if you give her things that are going to change her foot, exactly, that will make her more compliant. So you don't need to do any of these bands with the hip. It's just not. Don't even bother. It's a waste of your time at this point. And I think for me is that a lot of the treatment and the exercise progression needs to be geared towards the driver of the problem, and what you found was the foot. And so that the treatment, and I know you would do that, it would be geared towards the foot. So just the listeners,
absolutely.
It's just that's how treatment has to be geared towards, not the hip at this point.
Right. And that's exactly why when we were on the phone, I encouraged her to keep doing that. I said, if that has made the change for you, then, she goes, well, I just want to know why it made a change for me. And I said, so physicians, so I love them all. I said, because it shares the same neurology as your hip. Oh, okay. Move along. You've got the reason now. You're happy.
Okay, I know. It's simple. That's awesome. So that's great. And I think you get the buy-in too, when you explain it, and then you give them a few things that will help them, and in terms, because a lot of patients are like, give me exercises, and I'm like, well, you don't really need to do much, and because I don't tend to give a ton of stuff out, as everybody knows from our podcast,
and you don't need to if you can do the right
you don't
things.
need to. Exactly, doing the right thing at the right time, and that's clinical expertise.
Yep.
There you go.
All right.
Awesome, great, fascinating, very fascinating. Cool. Hope everybody enjoyed it, because I certainly did.
Yes, thanks for listening, everybody. Don't forget, we have our website up, toughtotreat.com, and join our newsletter. That's where you're going to hear about some cool things for 2019. And Erica's book is out. You can get it on Amazon. Why Do I Hurt?
And Barnes & Noble as well.
At Barnes & Noble as well.
Problems.
I have a new online course for GI dysfunction that's on Embodia, www.embodiaacademy.com, out of California, but it's all online there. So if you want to check out my GI course, it's there. And more stuff coming in 2019.
Awesome.
All right.
And if anybody, our list is growing, so if you want to, I know Susan just mentioned this, but we've gotten a lot of great signups from our toughtotreat.com website. So if you feel you want to just opt in, we send a podcast email out every couple of weeks, but we will be sending more stuff going forward in 2019.
Right, and I think one of the things we announced on our very last podcast before this one was, if you've got somebody tough to treat and you want to come on and talk with Erica and I, we would love to have you. We're looking at probably doing something quarterly with guest people coming on with their clients and how they handled them and what other advice they might want, or we can talk about anything around that. That's tough to treat. So think about that if you'd like to be part of us.
Yeah, perfect.
Okay.
Sounds good.
All right. Thank you, everyone.
Thank
Bye.
you. Bye.